Yes, ma'am. We are live now, ma'am.
So, a very good evening, one and all. On behalf of Oxy Clinical Research Committee, we are privileged to invite you for the webinar on oncology. This month's theme, we all know it's Pink October. So for oncology, and we have really experts on this field, full people who are on hardcore oncologists, and they are going to give you all their insights, experience, and whatever you need to know about oncology, you're going to get all the information today. So let us start with the program for today. Thank you, Sheil. They have been our sponsors. So she is my co-chair, Dr. Deepa Tangamani. Madam is a senior consultant in Apollo First Med Hospital. She will also be with us. Next, please. So yeah, for people who don't know me, I'm Dr. Priya Kannappan. So I'm one of the executive committee member of Oxy. Next, please. So we would be getting our blessings from our president, Dr. Vijaya Madam. She'll be joining us shortly. She is the HOD of ESI Medical College, a retired professor, and head of the Department of Obstetrics and Gynecology Society, IOG, and retired director from there. And she's special interest in laparoscopic surgery and infertility. So next, please. And Dr. Geeta Lakshmi Madam, our secretary, she will also be joining us shortly. She's an associate professor now at present with Stanley Medical College, RSR. So we will start our today's session with the Oxy prayer. So I would thank God. In humility we gather, in gratitude we pray for all the good things you have given us. Shower us with our blessings to pass on to the healing touch, to celebrate the arrival of each new life and a warm reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and magnanimity of your endless love. Thank you, God. So with the Oxy prayer, I would like to start our program. So we have been doing this. Can we have the previous slide? So we have been doing the webinar every month in association with Foxy. So we know that Dr. Surika Tyagde Madam is a chairperson of the Foxy Clinical Research Committee. So Madam may be joining us shortly. Next slide, please. So it is my privilege to invite Dr. Mala Srivastava Madam. Madam is the head of the Gynae Oncology Unit, a senior consultant and professor of GRIPMA and Gynae Endoscopic and Robotic Surgeon, Sri Gangaram Hospital, New Delhi, President of Narchi Delhi Chapter 2024-26, Vice President ISOPAP 23-24, Past President AOGD 2021. And Madam is a FICOG, FIM, MCH, and she is also a gynae oncologist, gynae endoscopic surgery, gynae robotic surgery, minimal access surgery, and she's been trained with robotic surgery from France. And there have been many awards to her accreditation, and the best one is Foxy Achiever Award 2021, Sri Abdul Kalam Excellent Award, Dr. Subhash Muktopedia Women's Icon Award, Women's Medical Professional Award, Circle of Excellence Award from the ISOPAP. And there are so many credits to her society. Well, I mean, for her accreditation. Thank you, Madam. Thank you. Welcome to you. Next, please. So it is my pleasure to invite our speaker for the first session, Dr. Ajit Pai sir. Sir is an adjunct professor and a senior consultant in surgical oncology and robotic surgery at Apollo Cancer Center, Apollo Proton Cancer Center, and Apollo Hospitals, Chennai. He is trained in Tata Memorial Hospital, Mumbai, University of Nagoya, Kyoto, and Tokyo, fellowship in planetary surgery from Heidelberg, formal laparoscopic and robotic fellowship in UIC, Chicago. And he has awarded the Johnson's Gold Medal Award for the best outgoing student in medical school. We all know that in MMC, when you bag the most number of medals, at least 32 medals, so sir has got. So when you have the most medals, you get the Johnson's medal. So we all know that. And then it is about, he's already had 40 peer-reviewed publications and books and chapters. Welcome to you, sir, and over to you for your presentation.
Yeah, thank you. Can I start my presentation?
Yes, sir, definitely.
All right. Okay. So, is my screen visible?
Yes, sir, visible.
All right.
Yes, sir.
So my talk today, thank you to the organizers and Oxy chairpersons and Dr. Priya Kannappan for this invitation. So my talk today is about the laparoscopic and robotic demonstration of pelvic anatomy. And initially I thought, why specifically lap and robotic? And then I realized it's because it's so easy to demonstrate anatomy when we have minimal invasive, whereas with open surgery, even though there's a beauty in open surgery. Like today I did a patient where I had to do a pelvic node dissection and peritectomy open, but it's so difficult for the assistant to even take a photograph. So all the documentation is lost. So I think it's a big blessing that you have minimal access because one can demonstrate what one does and one can teach people very effectively and easily with the laparoscopic and robotic approach. So I'm going to take you through pelvic anatomy, basic introduction, what are the structures which are at risk when we do the pelvic surgery, what are the important pelvic spaces, and the robotic demonstration of pelvic spaces, and the robotic demonstration of a pelvic node dissection. I'll also talk to you briefly about sentinel node biopsy because um, whatever we do, talking about lab and robotic anatomy, finally it has to come to fruition in actual procedures. So sentinel node biopsy, radical hysterectomies, and pelvic node dissection. Now we no longer perform the type 3 radical hysterectomy of CS cervix by minimal access after the LAC trial. So I've removed that from my presentation. So it's just going to focus on the spaces and how they are relevant when we do a sentinel node biopsy or a formal pelvic ileoobturator pelvic nodal dissection. So gynec malignancies, we know they can be very early localized tumors, very early endometrial cancers such as stage 1A endometrioid to locally aggressive fearsome tumors in the pelvic region. Also, tumors can secondarily involve from, say, a pelvic side wall tumor or a rectal tumor can secondarily involve the gynecological organs. And one needs to be very conversant with three-dimensional anatomy of the pelvis to be able to effectively participate in teams which remove these organs, such as concentration team, or a short of an ablative procedure when you want to do procedures which are short of ablative also. Our knowledge of anatomy has to be extremely good. So if you look at the vascular anatomy, because finally one is worried about bleeding and injury to the ureter, these are two important things of concern whenever one delves into the pelvis. So the external iliac artery obviously is the most important artery because it cannot be ligated or sacrificed. It travels along the iliopsoas muscle. Now, important thing is there are no branches of the external iliac artery on the anteromedial aspect. There is only the inferior epigastric artery, which comes from the anterior surface very distally, and there is a circumflex iliac vein which crosses over and drains into the external iliac and forms the distal limit of ileoobturator node dissection. The absence of major vessels along the medial aspect of the external iliac artery allows one to perform surgery in natural tissue planes without the fear of bleeding. If we look at the internal iliac artery, it is a much more complex vessel, and it has an anterior and posterior division, as one is aware. The anterior involve the visceral branches, and the most important is the superior vesical artery, and in women, the uterine artery, which may come from a common trunk with the superior vesicle or independently. And the internal iliac travels parallel to the ureter and lateral to it, and then gives off the first division, which is the only vessel to cross horizontally over the ureter on its way to the pelvic organs. And it continues, the internal iliac continues, we know as the obliterated hypogastric artery, producing the umbilical fold, lateral umbilical fold. Posterior division is not very significant, and usually it can only if you do bilateral ligation, for example, of internal iliac arteries, you may end up with luteal claudication. Now, when you dissect the ureter, the first structure which crosses the ureter and obstructs the safe dissection of the ureter is the uterine artery. So there is no direct blood supply or segmental blood supply to the ureter from any of the pelvic vessels. So it carries its mesentery and blood supply from above and below. So one can easily dissect the ureter, provided one keeps the facial covering of the ureter intact without any fear of devascularization. Sometimes if you have a radiated ureter, of course, you can have problems, but generally the ureter tolerates dissection well, provided you don't use excessive diathermy near the ureter and use scissors or bipolar dissection. The internal iliac vein is a feared vein because bleeding from it can be troublesome, and it runs parallel to the artery and slightly deep. So when you're ligating, you should be careful to ligate only the internal iliac artery, not the vein, because the vein, when you take, it can cause venous congestion and troublesome bleeding. Another important point is that there is only one lateral branch of the internal iliac artery, which is the obturator artery. So again, the pelvic nodal dissection generally is quite bloodless because there are no major vessels. As long as you don't go deeper than the obturator nerve, you will not encounter troublesome bleeding from the internal iliac vein. The only lateral branch, as I mentioned, is the obturator artery, which runs into the lateral paravesical space and goes deep to the obturator nerve, as I will show in one of the videos later. So the uterine artery, of course, the most important artery, runs anterior to the ureter, and the uterine vein runs posterior to the ureter. So they ensconce the ureter. So one anterior and one posterior. So when one is ligated in the uterine artery, one has to be very careful because laterally the artery and the vein are quite close, and one may go through the uterine vein leading to troublesome bleeding. So it is good to ligate it close to the ureter so that the vein and artery are diverging as the ureter passes through the gap between the artery and the vein. And nerves, of course, there are many. I'm not going to focus specifically a lot on the nerves. So the pelvic structures are all innervated by branches from the sympathetic and the parasympathetic. The sympathetic gives rise to the hypogastric plexus around the root of the IMA and continues downwards as the hypogastric nerves. And the pelvic splanchnic nerves supply the parasympathetic fibers, and fibers from both form the pelvic nerves, which innervate all the organs. So nerve sparing radical hysterectomy, which is typically identifying the inferior hypogastric plexus and nerve, and dividing only the uterine branch and preserving the bladder branches. So this will depend on a good knowledge of the spaces of the pelvis, so that you can preserve only the nerves which are going to the bladder and divide the branches going to the uterus. So the spaces, which are of course what fascinates surgeons, because these spaces are typically avascular, and dissection of these spaces prepares the anatomy for radical operations. So they are actually virtual spaces. They are not actually present, but they're created or developed once you dissect, or if you do laparoscopy or robotic, one is familiar that the gas which comes in will dissect into the planes and open up the planes. So they're actually virtual spaces. So you have bilateral spaces which are pararectal and paravesical, and you have unilateral or midline spaces, which is the prevesical anterior to the bladder between the rectum and the vagina, rectovaginal, and the retrorectal or presacral space. Now, the pararectal space is a very important space which lies lateral to the rectum on either side. So the ureter runs through the middle of the space and divides it into a medial space known as the Okabayashi space and a lateral space which is called the Latsko space. Now, the Okabayashi space is very important because it honors the surgeon Hidekazu Okabayashi, who as early as 1921, so long back, did the first nerve-sparing radical hysterectomy at the Kyoto Imperial Hospital and was very famous for his demonstrations. So the clinical and surgical significance of this space is for nerve-sparing radical hysterectomy, where we can divide the space, dissect the medial fibers of the uterosacral, leaving the lateral fibers so that we can preserve the nerves going to the bladder. So the roof is the posterior leaf of the broad ligament, medially there's the rectum, laterally there's the internal iliac artery, and cranially and anteriorly it terminates in the uterine artery, and the floor would be the levator. So basically it is, you see the uterosacrals and you see the ureter laterally, that is the pararectal space. Anteriorly, as you dissect with your finger or if you're doing laparoscopy with your dissector, you will encounter the uterine artery crossing the ureter, and that is the end of the space. So medial to the ureter, it's a medial space of Okabayashi, lateral is the Latsko space. That's all it is. Quite simple. And then you have the paravesical space. Again, so this space is basically, as it's intuitive, bounded by the bladder medially, laterally the pelvic wall, and inferiorly and posteriorly the uterine artery. You can see this depiction, which shows beautifully the left paravesical space and left pararectal space. The uterine artery crosses piercing the Meckenroth's ligament and divides it into the anterior and posterior spaces. So the medial paravesical space is very important because that's the space you dissect to do when you do a radical hysterectomy to get more of the parametrium and paracolpium. The lateral space is lateral to the obliterated umbilical. So that's the continuation of the inferior hypogastric. And the lateral space is where we find the obturator nodes when you do an ilioobturator nodal dissection. So, sorry. So the rectovaginal space is a retroperitoneal space outside the pouch of Douglas. So you have a pouch of Douglas peritoneum, and there is a fascia beyond that. That is the rectovaginal space. There is a denonvillous fascia once you incise the peritoneum of the pouch of Douglas. One layer covers the rectum, one layer covers the vagina. The important thing whenever you're doing dissection in the pelvis, the golden rule is all fat belongs to the bladder anteriorly and to the rectum posteriorly. So the vagina is devoid of fat. So that's the plane we follow because in lap or robotic, one doesn't have haptics. Lap, of course, you have some haptics. So everything is based on visual anatomy. So when you see fat coming on the vagina, that means you are intruding to the rectum. And similarly, if you see fat in the vagina anteriorly, you're intruding to the bladder. So as long as the vagina is clear of fat, you're on the right plane. So there are other minor spaces, which is pre-vesical anterior to the bladder and retrorectal. So retrorectal space is important because that's the plane in which we dissect the rectum. So between the visceral and parietal fascia of the rectum, what is called the holy plane of Heald is where we dissect for rectal tumors. It may be relevant when we do exentrations in the ambit of gynec oncology. Yabuki is another minor space. Basically, it is the space where the ureter inserts into the bladder. And it is very important here to preserve the branches which run along the ureter to the bladder in nerve-sparing radical hysterectomy to prevent urinary complications. This is a busy slide which basically shows the spaces. So you can see the anterior paravesical space, the posterior pararectal, how it's divided into medial and lateral spaces. So this is I hope the video plays. This is just a demonstration. So here you can see the round ligament anteriorly, and we always start in pelvic surgery, any pelvic surgery, by dividing lateral to the IP ligament. Once you divide that, the first structure you will see will be the external iliac artery and vein. We never see the ureter immediately. So that is important. So always it is the iliac arteries, then deeper and more posterior, you will see the ureter. And then the dissection can proceed along the ureter, medializing it. And then as you proceed along the ureter, at one point, you will see the uterine artery crossing from the internal iliac. You can see the uterine artery, which is the only vessel to cross the ureter transversely, and the internal iliac proceeding as the obliterated umbilical. So there is a fascia along the obliterator, which is called the vesico-hypogastric fascia, which needs to be dissected when doing a radical hysterectomy. And these are all the nodes along the iliac artery and vein. This is what is part of the ilio-obturator dissection. So along the iliac arteries, external iliac artery and vein, the proximal common iliac vessels, nodes, and the obturator nodes. So the obturator nerve is the lower posterior and lateral limit of dissection. Below that, we only do it in prostate in men, or if you're doing a bladder cancer, because generally nodes are not positive below that level, and you can get troublesome bleeding from the internal iliac veins. So you can see the obturator nerve, internal iliac artery, vein, and the pelvic side vein. Generally, this is avascular, and with the use of energy devices in lap or robotic, practically bloodless, unless the nodes are extremely friable or inflamed. So again, here to recapitulate, ureter, uterine artery crossing, obliterated. You can see the medial paravesical space and the lateral paravesical space, lateral to the obliterated umbilical. Lateral space, as you can see, the obturator nerve is passing through. That's where you find the obturator nodes. So just briefly to talk about sentinel node biopsy, because that is something which will be very relevant to everyone in this audience. So we have different pathways. So you have an upper paracervical, lower paracervical pathway, and of course, an infundibulopelvic pathway. So upper paracervical runs along the uterine artery and then drains medial to the medial external or obturator nodes, crosses the external iliac artery. So basically, it runs lateral and continues to the common iliac artery to the lateral precable and para-aortic areas. So that's called the upper paracervical pathway. Now, why it is relevant is these pathways need to be seen when one injects a dye like methylene blue or indocyanine green. You can actually see these pathways. So there's a lower paracervical pathway, which is along the uterosacral ligaments. And this runs more medially to the medial para-aortic and precable areas. And then we have some communication, which leads to the presacral nodes between the right and left pathways. So these pathways are very relevant, and one needs to know that when dealing with gynecologic cancers. So here you can see the lymphatic mapping when you do sentinel node. Most of the nodes are actually found along the iliac or obturator. You do find some amount of para-aortic nodes, but very rarely are they positive. So common nodes are the external iliac nodes, internal iliac nodes, and the obturator nodes. If these nodes are surveyed, more or less you will find the sentinel node, and these are usually the ones which are positive. Similarly, in cervical cancer, the nodes which are commonly positive are the iliac nodes and obturator nodes. Very rarely do you find nodes in other areas which are positive. Different tracers can be used. Our experience with in Apollo is the best method is indocyanine green. Blue dye, actually, a lot of times you will not find that it penetrates deep into tissue, and you may not be able to find the nodes on both sides. Only in about 50% of patients, you find the blue dye going to a sentinel node on both sides. If you don't find a sentinel node on one side, you have to complete the hemipelvic nodal dissection. So ICG actually gives you the best sensitivity negative predictive value for sentinel node biopsy. So the way we do is we take indocyanine green, which comes as sterile vial, mix it with 20 ml of water, it contains 25 milligram of powder to make it 1.25 milligram per ml. Of course, there are different protocols. This is what we use. We inject at 3 and 9 o'clock, total of 4 cc, 1 cc superficial at 3 and 9, and 1 cc deep into the stroma of the cervix on each side. Following this, if you're doing robotic, which is what we commonly do, we are already docked with the robo with the instruments. The moment it is injected, we start opening the spaces. And what we look for, as you can see, this is a streak of green dye. We look for the lymphatic channel, not the node as such. So this is the demonstration of a robotic sentinel node biopsy for a grade 1, stage 1A endometrioid adenocarcinoma of the endometrium. So once the dye has been injected and the robo has already been docked, so we use 3 arms. So there is a bipolar fenestrated, there is what is called as another grasper called a caddy, and we use a scissor to do the dissection. As you can see, we always open lateral to the infundibulopelvic ligament all the way up to the round ligament. This is on the right side. And here again, the important thing is all fat actually goes to the pelvic side wall. There is no fat in the IP ligament. So you push all the fat laterally and just take the membrane. So that IP ligament is just a membrane with a blood vessel. So all fat is pushed laterally. So that's the key to any pelvic nodal dissection. So divide it all the way proximally and gently and very, I think you can see the ureter there moving well. And we are very careful not to cause bleeding because bleeding will obfuscate the ICG. You can see the ureter there, and we open up the spaces. So that's a pararectal space which has been opened, the lateral pararectal, and anteriorly will be the paravesical space. You can see the depiction: extrailiac artery and vein, ureter, and IP ligament, and the 2 spaces. So that is the paravesical space, and here below is the pararectal space. You can see the ureter nicely moving. So once this anatomy has been demonstrated and all the spaces have been opened nicely, we put on the firefly mode, which is basically near infrared fluorescence. It shows the dye. The dye is not visible as such to the naked eye initially. You can see there's a lymphatic streak going probably to the obturator. Now we convert to normal white light and we dissect the node because you can't dissect completely under ICG because you will not see the anatomy. But we keep on checking to see, you can see the streak going to the obturator. So this is the right sentinel node which has been identified. And then we take out the node. And we don't need to send a frozen. Once we are sure it is a node, a frozen is not required because if the node is positive, then the patient requires pelvic RT. So a pelvic nodal dissection is not therapeutic in endometrial cancer patient unless it's an isolated recurrence coming after initial treatment or something. So there is no need to send the node for frozen as long as you know it's a node. But let's say you take out tissue and you're not sure if there is a node, then you should send it to the pathologist to see whether it's a node. Here you can see it is still fluorescing. A similar process can be done on the left side. Again, there's an avascular plane. You open it lateral to the IP ligament, let the gas dissect. Pretty standard and straightforward. You dissect, you can see the membrane, push all the fat laterally. Go all the way down. You can see the iliac artery and vein coming into view there on the left of the picture. The psoas is seen. So once the spaces are nicely dissected, then we can switch on the firefly mode with the robot. So this is the firefly board. You can use something called a spy with other systems like Stryker or Karl Storz. With robotic, it is very simple because it's inbuilt into a machine. Again, you can see the lymphatic was there. And this is the upper paracervical pathway, which runs along the iliac artery and goes laterally. So the node is dissected. We can keep checking with firefly in between to make sure that we are indeed taking out the fluorescent node. And then this node, in the initial part, of course, we do send frozen to make sure there is a node, but otherwise later on you don't need to send them frozen. So that's how you do a sentinel node with the robotic. The last video I'm going to show is about lateral pelvic node dissection, proper pelvic node dissection for a patient, I think, where the sentinel node did not pick up, if I'm not mistaken. So we have to complete the pelvic node dissection if the sentinel doesn't pick up. So this is, so again, the peritoneum has been incised. They open up the pararectal and the paravesical spaces. You can see that the round ligament has been transected with an energy device. And you can see the ureter there in the lower, just below the fold that the assistant is holding. And here again, the structures have been the iliac artery, vein, ureter on the right side. an internal iliac artery. So dissection will involve removal of all nodes along the external iliac artery and vein, all the way up to the circumflex iliac vein crossing the artery, proximally up to the bifurcation of the ureter crosses. Medial, medially, hello.
Yes, sir. Yes, sir. We are clear. Yes.
Medially, medially it goes along the I think somebody's talking. They need to mute the mic.
I've muted them, sir. I've muted them.
Yeah. So medially it is along the obliterated umbilical, and infralaterally it is along the pelvic side wall, with the obturator being the posterior alignment. So here the obturator nodes are being taken out. Like I said, it's very important of cognizant two structures. One is the internal iliac vein. Second is the obturator artery, which crosses laterally from the internal iliac and passes below the obturator nodes. So they can lead to troublesome bleeding, especially when you're doing minimal access. So actually, more than open, you can do a very good operation when you do robotic, because your vision is so much better and you're able to dissect the vessel almost circumferentially compared to open surgery. So actually, we find that when you transition from open to minimal invasive, we are actually able to have a better yield of nodes, a more satisfying nodal dissection. So here we're dissecting lateral to the external iliac artery. We will go up to the genitofemoral nerve and expose the psoas. So these are the external iliac nodes being taken all the way up to the bifurcation. So very important that when you do the proximal iliac, common iliac node, that the external iliac vein, or the common iliac vein rather, will be lateral to the artery and then gives off the external iliac vein, which proceeds medially. So laterally, when you go, you have to be careful. You can see that the vein is just there. That is the genitofemoral nerve coming into view, which is the lateral limit of dissection. Dissect along the nerve, preserving it, of course. We don't need to go laterally. There may be sometimes nodes which are lateral to the thing. One can remove these nodes, but generally, routinely, we don't remove these nodes unless there's an obvious node, because it can lead to troublesome lymphedema if all the lymphatic channels are removed. Constant node is usually there, and there are a lot of lymphatics who need to be coagulated to prevent troublesome, chylous effusion, chylous ascites post-op, which can be a problem with extensive dissection. We generally don't keep a drain at all. Sometimes patients require a pictorial insertion, but routinely we don't place a drain unless we have done some bowel resection or something concomitant in the pelvis. That's a dissection along the iliac artery, which is now almost circumferentially bad. So this is the advantage of robotic, that as you keep pulling, you can go very deep to the artery and lateral to the artery also, because the vision is very good. And many of these patients are very obese. So, in open surgery, though it feels like we can do a good dissection, really because of obesity and bowel falling, one really struggles to do this quality of dissection. And that's the iliac node and the proximal common iliac node also being taken. A careful short bursts of energy are required. But the control, of course, is very good because of robotic and absence of tremors. With laparoscopy, one is always worried about pass pointing or touching a structure such as ureter. That doesn't happen with robotic. And again, this is of course a three-dimensional image being represented as two-dimensional. Our actual view is even better than what you're seeing here. And we generally don't need to use clips and other structures. The coagulation is fine. So you see a nice nodal packet from the iliac. And once this is done and we've taken all the nodes, then we will go more medially and posteriorly to take out the obturator nodes. The artery has been completely skeletonized. And we go along the vein next. And the assistant is invaluable for providing some gentle traction. So even with the arms, you need more traction. One can use a scissor or a hook. Actually, here you're using a scissor, but my preference normally for most dissection is to use a hook. So I was formerly trained in robotic in the US. That's most surgeons there use a hook, because a scissor was not initially available with the Da Vinci. It was only recently, not recently, but after a few years. The hook is what most people started off with. You'll find most formally trained surgeons will be very comfortable using a hook during a robotic rather than the scissor. see, I think the operator now will come shortly into view. One goes distally. Again, the distal limit is not the inguinal ligament, but the crossing of the circumflex iliac over the artery. The operator now you can see there. One should be careful not to injure it because it can lead to troublesome weakness of the adductor compartment, difficulty in getting up from a sitting position. There are occasionally women who come with a complaint of neuropraxia or weakness of the medial adductors, which can be quite troublesome for somebody to get up from a sitting position on the floor. That's the pelvic side wall. Sorry, my mistake. That was the internal iliac artery, not the obturator. So you can see the internal iliac becoming the obturator. There is the. So here I think we have injured the obturator artery. That's what I'm saying. It can cause troublesome bleeding. One should be very careful that it will come below the obturator nerve and coming from the medial aspect from the internal iliac. You can coagulate the vessel without any issue. And the obturator nerve sometimes can give an obturator jerk, so one should be careful when that happens because suddenly your diathermy may jump. And take the node all the way up to the pelvic side wall. So this vision actually is very good with lap or robotic because you can actually go very deep under the iliac vein and see around corners. That's my presentation. I think didn't want to keep it very extensive, but basically told you about the anatomy and demonstrated a few videos showing the important spaces. So the cardinal thing is knowing how to do a good pelvic nodal dissection and sometimes avoiding it or oftentimes avoiding it in patients with endometrial cancer by doing a sentinel node. Because if it is positive, one doesn't need to really complete the pelvis. But in patients who don't have a sentinel node or you don't have the facility, you must know how to do a good pelvic nodal dissection. It is invaluable, and the knowledge of spaces is very important. It's not complicated, but it is complex. So, thank you for your time.
Thank you, sir. Thank you. That was such an elaborate discussion. Dr. Sureka has joined us. She's a chairperson, Foxy Clinical Research Committee. Welcome, Dr. Sureka, madam.
Good evening. Yeah. I'll
Madam,
stop
you're
sharing.
muted. Yes, sir. Yes.
Okay. All right.
Sureka, madam. Sureka, ma'am, you're muted. We can't hear you. Dr. Mala, madam, can you give us your words of wisdom? Yes.
Excellent videos, Dr. Pai. And you
Thank
rightly
you.
said that a laparoscopy view is much better than an open view. Because in open surgery, it's very difficult to show the anatomy to our juniors and our students. But when we are doing a laparoscopic or robotic surgery, everything is on the monitor. So not only the juniors can see, in the entire OT theater, staff can also see the anatomy, and you cannot make mistakes also because everybody is seeing what you are doing. And we have a slightly different technique that basically what we do when we are planning to do a sentinel node, we make the ports, we dissect the spaces. Once we have dissected the spaces, then we inject the dye. So that we are very absolutely ready to take up the first node and delineate them and take it out. So I thought I will just share our trick because when we are doing this laparoscopic or robotically, what we do, we first dissect the spaces, dissect all the spaces out on both the sides. And then we go down, one person injects the dye. We use ICG dye. And then we quickly come back because one person is already there on the laparoscopic or robotic side. So we can start doing the dissections there. We have already opened the spaces. Understood. So that saves us a lot of trouble. Because once you put the dye from below and then make your ports, you go in pneumo and all that. So that will take some time.
No, we put the ports and the instruments. It's just that I don't open the peritoneum because I like to see the shine of the lymphatic pathway through the intact peritoneum before I open. So once we open, it's hardly...
We open the spaces out. We just don't do any dissection, just open the spaces out.
Understood. There are different ways. Yeah, there are different ways of doing it. It's just
Yeah,
whatever
definitely.
works
So
for
we
us.
just wanted to
Yeah,
share that what we do. And
sure, sure.
definitely, you had a lovely videos and nicely have shown the robotic
Yeah, yeah.
approach to the sentinel node dissection.
Thank you, thank you,
Congratulations.
thank you, ma'am.
Yeah,
Thank you.
thank you, Dr. Pai. I'm
Yeah,
Professor
thank you.
Surekha Saide, and thank you
Okay,
very much for joining us. And really lovely videos. And I
thank you.
must agree with Dr. Mala. It has been very recently that I've also started doing robotic surgeries. So
Okay.
I really find it, wonderful. The way the vision is, the way we are able to, go to those deeper planes and, really wonderful 3D vision and lovely videos. Thank you very
Thank you,
much for
thank you.
joining us.
Thank you so
Thank
much.
you.
Thank you for, yeah, thank you for inviting me. Thank you. Yeah.
So thank you, Dr. Anbu, madam.
Hi.
Hi. So your words of wisdom, your opinion, like how do you do anything?
So I do it very similar to what Dr. Ajit has just detailed. I do the dye. Can you hear me?
Yeah, we can hear you.
Yeah. So I do Dr. Ajit's method as well. So I just place the ports. I don't open the spaces for fear of causing any bleeding or interrupting the lymphatics, which could actually be taking those dye to the nodes. So I do the injection first and then put in the instruments and start doing the dissection. So that's how I do it. But it's fabulous to see it in real time, to see the dye moving in through the lymphatics and to actually be able to avoid the entire process of lymph node dissection, because it is quite cumbersome. It's also difficult, especially in the category of endometrial cancer patients, because they are obese and they have multiple comorbidities. So they do land up having complications like lymphedema and lymphocysts. So I think sentinel lymph nodes have that way really revolutionized lymph node dissections. And we don't do complete lymph node dissection, even if they are positive. So there is no need to do a frozen section, because there is no value of doing a lymph node dissection in terms of survival outcomes for endometrial cancer patients, unlike vulval cancer patients or breast cancer patients. So it's just important to pick that node out and send it for a complete histopathology with ultra staging. And that's important as well. Yeah. Thank you, Priya.
So thank you, madam. Thank you. So thank you, Dr. Sir Paisa. So there is a question, like you told about the obturator nerve injury. So the patient may find it difficult for her to get up from the sitting position. So is it permanent? You cannot do anything, or is it temporary? Just the neuropraxia, it is going to recover on its own.
So what happens is that obviously if the nerve is completely charred or damaged, then it'll never recover. Usually that doesn't happen. So what happens is there is usually, as you're dissecting, you may get a jerk and your diathermy will just spark. Typically it happens with laparoscopy, because obviously there are tremors. Whatever you do, there will be slight tremors at the tip of your diathermy hook and all. But with robotic, we have not had any. We have had a few with lap. Now, more or less, unless the patient has really constraints, we generally go for a robotic procedure. And because we do sentinels, only in those patients where we can't identify a sentinel node, or for some logistic reasons, we are not able to do a sentinel node, we do a pelvic. So our pelvic nodal dissections have actually dropped quite a few, but we don't do as many as before. So usually if it is just a touch, a neuropraxia, it is temporary. Usually it will recover within 3 to 6 months, but it is very troublesome because patients will continuously keep asking you that I was fine and now I can't get up from the sitting. And obviously we don't tell them the whole story. But in a patient who has this problem, they can't sit on the floor and get up, because lady wants to sit and eat on the floor. Traditional lady is not able to get up. So that is a big disability for them. So one has to be very careful with the obturator. I learned that the hard way. Yeah. Yeah.
Sahiti, can you hear me?
Yes, ma'am.
Yes, thank you. So thank you, sir. That was such a wonderful video session. So a lot of congratulations from every, both in the
Thank
chat
you.
group as well as from all the Ogician and Oxy
Yeah.
group. So thank you. So
Thank you
for
for inviting.
accepting our invitation. Thank you, sir. Thank you for joining.
Thank you.
Our next speaker for this session will be Dr. Anbukani Madam, Anbukani Subayan Madam. Madam is oncologist from European Society Certification in Gynae Oncology, a consultant gynae oncologist and robotic surgeon at Kovar Medical Center and Hospital, Coimbatore. She is a current academic position is the editor of Oncology, the European Journal of Obstetrics, Gynecology and Reproductive Biology. She is a member representative of the International Representative Council, South Zone RCOG India. And she has had awards in Australian Society of Gynae Oncology Fellowship and Clinical Attachment, North Royal Shore Hospital, Sydney, Australia in 2014, and in Shingo Fuji Young Doctors and International Gynae Cancer Society Fellowship, Lisbon, Portugal 2016. So I think most of our RCOG members, we know very well about Anbu Madam. And for others, she's a very good academician and she's been the editor. So she is going to tell you how to publish an article on an editorial perspective. So if you're really interested to bring your article into a good journal, she's the best person for you. Over to you, Madam.
Thanks, Priya, for that kind introduction. Can I share my presentation? Right. So thank you for this invitation. If there is one job that gave me the most imposter syndrome out of all the jobs that I've held, this is the one. Because personally, I do not have any high quality publications, but I still was elected or selected to become a specialty editor for oncology for the European Journal. And I work with very senior people who have published extensively. And this was the one job that really gave me a lot of fears and doubts of whether I would be able to do the job. But it's been 2 years now. And additionally, I'm also an associate editor on the Indian Journal for Gynecological Oncology, which is very recent. It's been about 3 months since I started my job there. So this presentation is basically more for the younger audience in this group on how to actually write a good article and potentially get it published in a good journal and get good citations out of it. And I'll try my best to see what I can share from an editor's perspective. So publishing a peer-reviewed journal has been a long-drawn process. The first journal that actually the article was published was in actually 1665. And peer review is more or less a recent process now. But you can see in this graph how publications have exploded across the globe. The rate at which medical literature technology outputs of research is coming out is just mind-boggling, and the growth has been exponential in the last decade or so. This was the first article was actually published by the Royal Society of London in the journal Philosophical Transactions, and in the last, this graph basically shows how the curve is rising. Let me just take you through how the publishing industry has been over time. Right from the time the first journal actually came out, which was in 1580. In 1989 was when, most of us who are millennials will be aware of the World Wide Web. We cannot exist without this. And this is the person Tim Lee, who basically came up with the concept of World Wide Web as part of the European Society for Nuclear Research, which is CERN, based out of Switzerland. After that, the way we communicate with each other, the way we talk about science, the way we compare our results with international institutions, our own institutions, has completely changed. A lot has happened in the last 3 to 4 decades. Google came out in 1998 and basically changed the way we are looking at published literature. A lot has happened. PubMed has come out. Creative Commons came out in the year 2000. Google Scholar came out. Biomed Open Access came out. But in the last few years, since Facebook came out and about a billion people that live on the planet are on Facebook and different social media, there has been a complete rehaul of how we share literature as well. We don't look at published journals, holding it in our hands, taking it out of libraries anymore. Most of the people have now gone down to an attention span of maybe 30 to 40 seconds. And information is also shared in small chunks, which makes the way we write articles, completely different. So we want to be precise, concise, and give the most crucial information in how we write, right? So let me take you through what happens at Elsevier. Elsevier is the parent company that publishes the European Journal of Obstetrics, Gynecology, and Reproductive Biology. They publish about 7,000 journals, and this is basically the publishing cycle. Currently, there are about 10 million articles in the archives of Elsevier. And how we actually manage this is, as soon as the articles come in, they are split between about 7,000 editors that work with Elsevier. Most of the articles, in fact, the rejection rate, which we call as desk rejection, where as soon as the editor sees the article, they're rejecting it straight away, can be anywhere between 30 to 60%. A couple of weeks back, we had the EJOG editorial board meeting in Amsterdam, and I was there, and each of us was presented the data of what our desk rejection rates are. And the desk rejection rates at EJOG especially is about 80 to 90%. Most of the editors are not accepting articles unless they are very high quality. This 30 to 60% is across all the journals that Elsevier is publishing. So it's rejected right at the entry point itself. In most of the journals, and EJOG has not been a very high impact journal. You've got BJOG, you've got the ACOG journal, which is the American Journal of Obs and Gynecology. You've got human reproduction, you've got fertility, sterility. All of these would have an upwards of 95% desk rejection rate. So you've got to have really high quality papers to publish in journals like the Lancet and Nature and Science. Once your article gets through the editor, what happens then is it goes on to the reviewer process. We have about 5 lakh reviewers. A lot of reviewers are not even accepting peer review anymore because of the sheer number of articles that are getting into the peer review process. So as an editor, we find it very difficult to get reviewers. If you are interested, please get in touch with me to become a reviewer on EJOB. But that's what happens next. We send it off to reviewers. The minimum number of reviews we need for each article is at least 2. So the reviewers do not are blinded to the place of origin of the paper, and they go through the paper and they give their independent review. If the articles are published, about 500,000 articles are accepted every year. And if they are published, then what happens is the production cycle happens, which is basically editing, looking for errors, going through the journal, polishing it, and then making it available online. Most of the journals now don't do print anymore. They are available only online. Therefore, you need to have access to www to be an avid reader of these articles. Once this gets published, then it's all about citations. They are available for readers either by payment or without payment, which is called open access. And more than 480 million downloads have happened so far out of all the Elsevier journals in about 180 countries. And this is the work of about 30 million researchers, as we know today. So this is about what happens in the publishing industry. It's a billion-dollar, multi-billion-dollar industry, but individually, are you ready to publish? So when are you ready to publish? There can be one out of these 3 scenarios. One thing is that you have completely new results. You come up with a path-breaking result and you're out there. It's original. You've conducted a study and you want to publish it, then that's a new or an original result. The second thing that you can do is revisit. Suppose there is a path-breaking trial that has been published. Say, for example, the CRASH trial, which published tranexamic acid and its impact on mortality if administered within the first 1 hour of a road traffic injury. Then people go on to extrapolate that data into multiple different scenarios to the extent where, for example, if you have an elective case today, it's a common protocol in many operating units to give tranexamic acid at the time of the incision, which can then reduce the amount of bleeding that happens during surgery. So that came out of the extrapolation of the CRASH trial, right? So then you go on to do something like that, which is reinventing the wheel. The third thing that you can do is review already published articles, kind of collate the data and put together an overview of that particular topic, which is what happens in a systematic review or a meta-analysis. So any of these three things is usually considered good quality data by good journals across the world. So this is the general structure of a research article. So once you decide, okay, this is what I'm going to do, and you want to publish an article, this is the general structure. So this is in 3 sections. The first section is your title, abstract, and keywords. This is the most important part of your article. People these days, with their 30-second, they only have 30 seconds to read your article. And if they don't find your title interesting, they are going to move on. If your title is not worded properly, it's not going to be picked up by a Google search, and therefore it will not reach the right audience. But suppose your title catches the interest of someone who is Googling to learn more about that particular topic, then they only have a 30-second attention span. They're going to read the abstract, and if they are captivated by what that study shows, then they go into the main paper. If not, your study doesn't even go into someone reading the main section. So this is the most important part of any article. The second part is the introduction, methods, research, and discussion, which goes by the acronym IMRAD. So that gives the pith of the article, which tells you how the study was done, how did you do the study, which is the methodology, what results did you see, and finally, what are you going to put out to the world in terms of your results. Last section is the conclusion, the acknowledgements, references, and supporting materials. I'm going to go through each of these sections in a very brief manner. Of course, it's always important for you to read if you want to present to a particular journal, then you've got to go through the guide for authors to look at how each journal wants this to be structured, and every journal has its own structuring. So when you look at a manuscript title, this is what attracts the reader's attention. Therefore, it needs to be really pithy. It needs to be concise and informative, because if this is not attractive, your article is not going to be read. And that's the whole point of getting it published, right? And it's also very important to not use technical jargon and abbreviations, because abbreviations are different in different parts of the world. Like we say USG for ultrasound, that's not recognized by many people in the West. So unless it's a standardized acronym, say for example DNA or something, which is like commonly used all over, it's best not to use abbreviations. Editors, reviewers generally do not like titles that make no sense or failed to represent the paper accurately. So there's no point pulling a very attractive title just because you want to make it sound flowery. And if your title is not appropriate, as I already said, you're not going to draw the right audience. So the next line is usually the authors, right? So the good listing principle is to have the first author, and that, according to international publication recommendations, is the person that's been most involved with the design of the study, with the person who conducted it, collected the results, collated the data, and actually writes the paper. The corresponding author can be the same first author, or it can be a senior person, so that they can answer the reviewer's questions. Do not do ghost authorship or gift authorship. Ghost authorship is basically avoiding putting down someone's name, even though they were involved in the trial, because you want to get back at them. That's not done. You have to give due acknowledgement to all the people who were participating in the trial. And gift authorship is basically getting your senior's name included in it because you want to get some brownie points. So that's not recommended as well. Now, the third section is the third point in the first section is the keywords. Now, these are how your articles are going to be picked up by Google search. And therefore, it's very important for you to get on the right keywords. These are used for abstracting services and indexing services. They should be very specific. For example, if you have an article title, which is, like say you're looking at a study on a tube solar collector using carbon dioxide, supercritical carbon dioxide, then these words have got to be there in the keyword section. So it's very easy. Just pick out the most important words of your title. Coming to abstract, now this again is the one thing that most of the people who reach out for your article will read. They won't get past it if they don't find it interesting. So this needs to give it in a very important, in a very nice summary, the problem that you aim to address, what was the methods, results, and conclusions in a single paragraph. It has a very strong influence on whether or not your work is going to be considered for publishing. And keeping it as brief as possible is very important because people don't have time to read it anymore. Many authors will usually write this the last. This is not written at the first, when they start to write an article, this is not the first thing that someone writes. The abstract, many of the leading the authors across the globe, who have a high H index, will write this the last because this needs to be as pithy as possible. So I would compare the process of writing or building an article to building a wall. So this is how, even though you read your article as, title, abstract, keywords, and then you go on to introduction and methods and results and discussion, the writing of an article, I think would be better if it's written like this. First, of course, you design your study, you get all of your data in a place, you put it down into figures and tables. Then you write this section, which is basically you describe what you did, which is easy enough because you've done the trial. And then you describe the results from your figures and tables. And then you discuss the data points of what you're trying to convey based on the results that you obtained. Then you go on to conclude. You can write the introduction last. The title, abstract, and keywords can be taken out of your entire paper after you digest your own data points and what you've learned out of your trial to make it as interesting as possible. So in one word, title should be informative. Précis should be a take-home message. An abstract should be structured with key points. The introduction basically is what is the research question you're trying to answer. The methods will basically be, how did you do it? Or what did you do? What was the trial you did? Results, or what did you find? Discussion is basically, what does your result mean for the world of medicine? References should be uniform. You have a particular style that each journal will refer to. Declarations basically means that you're declaring funding and any conflict of interest. Finally, figures and tables, you need to follow the instructions of that particular journal as well. As far as the writing style is concerned, this is something that many people who are not English language, who do not have English as their primary language, will struggle with. But one thing is that people are looking at, good editors, good journals are looking at the science, and the language comes second. So try to keep it simple. Do not use flowery long sentences. It's going to make the editors jump off your abstract immediately. If you have any doubt about what you're trying to say, leave it out instead of including it. Avoid flowery adverbs and keep it as clear as possible. You can now make use of professional language services. For example, Elsevier does have language editing. It's available free of cost if your paper goes in for peer review. But many of the smaller journals, like for example, the Indian Journal doesn't have language services. So the editors are doing it themselves. I mean, we do it ourselves. But you can have professional language services, which are available all over in all the major cities, to actually correct your article and make it proper. So I'll just go through the next 5 slides are basically to give you an idea of about what goes on in each of these, the IMRAT section, which is the introduction, methods, results, and conclusion. So the introduction should give a brief context to the readers. It should make them understand what is the problem you're going to solve and how is it going to impact that particular area of medicine. Therefore, you address the problem. So if you're looking at how to, for HPV vaccination, I want to see what is the level of knowledge that the patient population attending a small primary health center that you're posted in has, so that then you can come in and offer solutions to addressing that problem. Then you talk about HPV awareness that's there around the world. And, this is the low level of evidence, that low level of awareness. And therefore, I wanted to look at what's the level of awareness in my area, right? So you address the problem, you identify some solutions and limitations and what your work is trying to achieve. But it should not be a history lesson. You can't go into 3 and 4 paragraphs of introduction. The introduction should again maximum be 1 or 2 paragraphs and keep it as simple, as brief as possible. The other thing is that when you there is a plagiarism check that many of these journals, the journals have. When we go into the system to review our articles, these articles get flagged up for plagiarism, and it gives us a percentage of plagiarism and double submissions. If you pick up sentences from another article and put it in your article, even if it sounds relevant to your paper, it will be picked up on plagiarism check. So you need to be original in the way that you write your sentences. Do not copy and paste from another article, because immediately it will be flagged as plagiarism. So now we go through to see if the sentences are common in certain areas, like for example, introduction, we are okay to let it go, and we just focus on the results and the discussion part. But you have to keep in mind that you can't copy paste from other articles. So methods basically describe how the problem was studied, right? This should be as detailed as possible. So if you've done a path-breaking trial and I want to reproduce the trial, I should be able to follow your paper and be able to do that in my setup. So if a Professor Arul Kumran comes up with a methodology to reduce PPH, you will look into the method section of his paper so that then you can do it in your setup to reduce the incidence of PPH. Therefore, this should be as described as succinctly as possible, but you do not have to describe previously, do not have to go into the entire structure of that problem and go into describing all previous procedures. Identify equipment and materials used. So for example, if you are studying sentinel lymph nodes and endometrial cancer, you've got to tell the dye, you've got to tell the manufacturer, you've got to tell us the dose of the dye, where you're injecting, how many ml, how long before the procedure, all of that needs to be in your paper. That is what is going to help your audience, right? The other important thing is also you need to have ethics committee approval for many trials, because experiments on humans and animals should follow ethics standards. There's a Helsinki declaration which needs to be looked into to see if you're ethical, and approval of your local ethics committee is also required. Having said that, just because you got ethics committee approval doesn't mean that editors will accept it as well. If they find that it's an ethical dilemma, and if you have played around with, with increasing complication rates, or you've played around with important interventions that could result in complications, then they may reject it based on their own ethical judgment. So we've got Declaration of Helsinki. The other important ethical aspects I already touched upon are plagiarism, duplicate publication. You can't send the same paper to 2 different journals and try and publish it. Can't fabricate results. You can't have ghost authorship, so on and so forth. And as far as methodology is concerned, for postgraduates who are listening in, this is the levels of evidence. So any journal is obviously going to place meta-analysis, which is 1A at the top. No one will say no to a meta-analysis. It will immediately go to peer review, randomized control trials. But having said that, It's the most important, the most difficult thing to do is run a randomized control trial. It's also very difficult to do meta-analysis. So you got to have a big team to do this. But a non-randomized trial, a quasi-experimental study, descriptive studies, correlating studies, case studies, or cohort studies are all relatively easy to conduct. Now, the other important thing is all of these different types of trials have certain reporting guidelines. So the first thing that the editor also looks at, if you say this is a case control study, or this is a diagnostic study, which is looking at the diagnostic accuracy of, say, a frozen section in sentinel lymph node, then you've got to go through these guidelines and stick to what these guidelines say. So these studies have to be conducted or according to the guideline for that particular type of trial. So a randomized trial, you have to follow the consort guidelines. For observational studies, you've got to follow stroke guidelines. So this is actually given free. This is the Equator Network. It's a free website. You can go into it. You can look at the standards and guidelines that are recommended for each type of trial. And you've got to stick to the type of the reporting guideline according to the study that you're trying to conduct. Now, coming to the last part is the results. Results should have only the data of primary importance. You can't be talking about all that you saw in that particular population. So it's got to match the aim of your study, and the result needs to be matched. Whatever extra you've learned from that trial can go into your supplemental data. So just stick to the data of primary importance. It's important to also use subheadings so that it looks attractive and eyes can be drawn to the most relevant data points. Make it easy to understand. Highlight main findings. You can point out to certain unexpected findings that you got in your trial. It's important to stick to statistical analysis, and it's important to involve your statistician right at the beginning of designing your trial. It's very important because statisticians provide a lot of input about the power of the study, how many patients you've got to recruit to make it meaningful, and also about what are the data points that you have to collect. So running to the statistician after you've collected data is going to be counterproductive many times, including it in the form of a table, illustrations, figures. All of this is important as well. Now, this is the most important section. This basically gives you an opportunity to convey to the reader what you have learned from your data. How does your data change science? What important change does it bring in practicing your specialty, that particular part of your specialty? How does it compare with international practice? And that's why you also have 3 or 4 major trials that have worked in this area, and compare your data results to international data or to bigger trials that have worked in that area. This is the most important section. Right. But importantly, don't go beyond what you have studied. It may appear simple to you, but simple is the most beautiful way of presenting a paper. Trying to make it complex, trying to go all around and beating around the bush is not going to work. So don't put in statements that go beyond what your results can support, and don't use non-specific expressions, and don't speculate based on what you have interpreted based on your imagination. It needs to be scientific. Conclusion needs to be very clear. Provide justification for your work. You can tell what else can be done in that area, how it can advance present state of knowledge, and future experiments that could potentially help advance science. So acknowledgements is all of these, your advisors, your supporters, any funding. References, again, don't use too many references. There is no use unless it's there in your discussion and your introduction. There's no use having too many references. You also have to absorb what your material you're referencing and use it in the correct area of your paper. Avoid self-citations because a lot of authors do that to improve their citation rates, and conform to the style given by your journal. Now, this is, I'm just going to take one more minute to tell you how we work and how we basically send it for the peer review process. So I'm only a specialty editor, so I take care of only the oncology part of the European journal. The editor-in-chief, who is Professor Janesh Gupta, in this case, takes the overall decision to accept or reject, but and to also do other things like retract articles. And if you are interested in publishing, you know that there has been a huge hue and cry about data being manufactured. Latest was in the field of Alzheimer's. A huge name in the US got pulled back. He was supposed to have done path-breaking work in the field of Alzheimer's, and all of that work is now proven to be fabricated data. So you've also got to keep abreast of what's happening in other areas. So I also work for the Indian Journal of Gynecological Oncology. I'm an associate editor on that. And again, there, Professor Somshekhar, he would take the final call on whether articles need to be accepted or not. So there's a lot of review that happens. Specialty editor is the first step, then there's peer review, and finally the editor-in-chief. So how do I look at articles? I look at the methodological structure. Has the trial group or the person who's submitting the data, have they structured their trial properly? Is this anything new to contribute to science? Does it take it at least one step forward? And is it within the scope of my specialty? If I am a reader, if I don't know much about that particular topic, will I be able to understand what the person presenting is telling me? And finally, will the reviewer be able to understand all of this and be able to give in his feedback? If it's an exceptional article, we send it for fast track review and publication. The three most important things we look at is it original? Is it reliable science? And does it have any clinical importance? It can be anything. See, we came up with prophylactic antibiotics. We came up with hand washing. All of these are not rocket science, right? These are simple things, but they've made they have huge implications on outcomes. Some of the common reasons for rejection are if the format is not consistent with our journal, and if they are flawed methods in the study design, inappropriate statistical analysis. Sometimes we do reject if the English is hard to follow, if they are unsubstantiated conclusions. If you talk about something, but you come up saying this is the only thing that has, proven to be the best, and this is how you need to do it, and all of that, then we immediately reject it. And if it's not really important to our journal. So I hope I have been able to give you a little bit of an idea about how to structure an article and, potentially some points about where you can look up for more information on this. Any questions, I'm happy to answer. Thank you so much for this opportunity.
Excellent, Dr. Ambu. You have rightly told how to proceed with a publication and how simply you've simplified the directions. But very important, the content has to be very good. The scientific material has to be very good. The results, and you rightly told you, first we have to compile the results and make the tables. Then we talk about the method, then describe the results, and then discussion. Yes, and then we come to the key points, that is the conclusion. And then, of course, we can go to the introduction as well as the abstract writing and acknowledgement, etc. This is the best way to simplified way to tell our juniors how to do a great publications. And definitely each article has, whenever we do the thesis also, we have to ask ourselves, what new are we going to do? How will it change the clinical practice, and how will it benefit or add to the existing scientific material that is already present? Then there is a relevance of this study or this publication. And then only we can classify which is a high-end subject to be published. And of course, our students need to do thesis. They are doing simple thesis, but everything need not be published, because as an editor, you have to pick and choose what is relevant and what will be adding to the existing scientific material as well. You have nicely told stepwise, and I'm sure all the viewers, all the delegates who have logged in will get a great idea how to publish the papers or to make their publications, write the publication in simple language, small sentences, not big jargons. We have to convey our message in a simple words. If you are using common language, you'll be commonly understood. If you're using a rare language, you'll be rarely understood or rarely appreciated. That's what our teacher, Dr. D.C. Datta, used to say. Use common language, you'll be commonly understood and commonly appreciated. Use something which is very rare, you'll be rarely understood and rarely appreciated. And that we remember every time when we are writing, communicating with our patient, talking to our seniors, giving any scientific deliberation. We try to keep our language as simple as possible so that our messages are conveyed directly. Again, I congratulate you for your excellent, excellent scientific deliberation on this evening.
Thank you.
Hi, Anbu. It's a great presentation. I'm sure it will be really useful for the young researchers. And the way you told how the research works has to be how organized, how clearly has to be presented to publish in the great journals. So one question, people now started using all these artificial intelligent websites like Copilot and so will it be really helpful for them to organize their presentations, or it will be the negative aspect?
We are not very happy for ChatGPT or any AI-based tool to be used in writing the article. The one area where we're okay to allow is for correcting the grammar and for correcting spellings. So that already we have Grammarly and we have tools which anyway correct the grammar, right? That is also a more or less an AI-based tool, right? Because it uses prediction as a component. Not the same as ChatGPT, but most of the bigger journals are now using tools to detect if it has been written using AI-based tools. Although because it's proceeding at such a rapid rate, it's very difficult for us to also create the right tools to detect ChatGPT aided articles. But I'm sure there are going to be, just like plagiarism checks, just like double submission checks, I'm sure there are going to be tools to check if it has been used in writing the article. It's going to come up very soon. But so far, the stand that most journals take is you cannot use AI-based tools to write your article. You can use it to check for grammar and for spelling errors.
But actually, the AI based is like excellent. Like we had a WhatsApp message of thank you from my friend. We really thought, what a poet you have changed, like, so brilliantly beautiful message of thank you. And finally said it came from AI, so nothing to be done from me. Like, the AI gave me a thank you note. My God, it was like, mind blowing.
Also, there is now AI based thing is there. Correct.
Yeah, even WhatsApp, it's there. But it raises a red flag, no? As normal people don't use words like that.
No, so we found out. He said, suddenly you became a poet. And
that's not done anyway. That's not done in the publishing world, at least.
Research. Okay. So any other questions, Priya, in the chat box?
No questions in the chat box. So Dr. Madam, you want to add on anything, madam?
Epsipa madam is also there.
Yes, madam has put excellent presentation. So, and Sureka madam was there, I think now she's not there. Epsi madam, you want to add on anything, madam?
No. Touched all what are all the format. It is very useful.
Yeah,
am I audible?
Yes, madam. Yes.
Yeah, you're audible, madam.
So that was a format we have to do it. And this chat GP and all, they can clearly make out. So it's not useful. Even in WhatsApp, this AI is giving a problem. Actually, when we type, see, my husband name is Oliver. When we type, it goes to Oliver Twist. So that is a nuisance for me.
Yeah,
so it was an excellent job done by Dr. Anbu. Thank you.
Very excellent. Thank you, Anbu. Thanks for the time. Priya, shall we move to the next?
Yes, madam. Yes. Sahiti, can we have the slides, please, for the third session? So, Deepa ma'am, you want to introduce?
No. Hapsi ma'am. Okay, so there is no need to introduce Sepsi Madam. She's known among all the postgraduates. She's a great researcher, and her book, Green Book of Obstetrics Gynecologist, the third edition is going to be released soon. And that book is very, very common among all the postgraduates, undergraduates, as well as all the paramedics also now. Welcome you, madam. Second time you are coming to our journal club. Thanks for your time.
Thank you.
And her PG, Dr. Raghavi, junior resident from CSA Kalyani Hospital, is going to present a journal. And topic of interest is soy isoflavones and breast cancer risk, a meta-analysis. Over to you, Raghavi.
There is a chat box. Dr. Anjalakshmi madam is also told a very good talk. So, madam, are you there, madam? Can you unmute, madam? Anjalakshmi madam? Not finding. 1 second. Should I ask?
Madam is a co-host now. Anjalakshmi madam? We are here to...
Yes, ma. Yes, Deepa.
Yes, madam.
I am audible? Am
yes,
I
madam.
audible now?
Yes. Yes,
Yes,
madam.
yes.
You are audible, madam.
Very clearly, Dr. Anbu Subbayan has very clearly told how to write an article. It is, if many postgraduates have attended, it's really beneficial to them. And how we can check how now people are there to write an article also. But that
Correct.
has to be used only for the English language, not for the other things. Okay. So it's very nice, Dr. Anbu. I am interested in research. We are producing papers. Okay. It is very useful to me also. Thank you.
Thank you, madam. Thank you for enthusiasm. Thank you, ma'am.
Okay.
And I would really like to, put it in the forum that we are in Oxy, we are inviting Dr. Anjalakshmi Chandrasekhar Madam's Research Award. So people who are interested, kindly, contact me or message me. That's the research based on diabetes, hypertension, preeclampsia, or endometriosis. So these are the topics. So this is a 1-year research is what we are looking forward. So you can just contact me for further details.
When is the last date, Priya?
Madam, last date they said we can extend because we are looking forward in the March. So, we are extending.
Okay, someone who presented in Jayashree Gajraj orations can present in Anjalakshmi madam's oration also?
Yes, topic only these three. Diabetes.
Yeah.
Yes, they can.
Okay.
They can.
They can. Okay then.
Thank you.
Okay, proceed. Raghavi, you can start.
A very good evening to everyone. Today, the topic of journal is soy isoflavones and breast cancer risk, a meta-analysis. It's taken from the journal In Vivo, published in March 2022, and it is the studies conducted by Ines Bajas et al. Soy contains genistein and diazine isoflavones. Isoflavones are phytoestrogens, which is similarity in structure to human 17-beta estradiol hormone. They imitate the action of estrogen on organs by binding and activating estrogen receptors. This results in a decrease in estrogen production. Soy isoflavones has been shown to reduce breast cancer cell growth to estrogen receptor independent inhibition of DNA topoisomerases and tyrosine kinases. And genistein has anti-angiogenic and anti-inflammatory properties, and this comes from the regulation of vascular endothelial growth factor and vascular endothelial growth factor receptor to expression. As we all know, breast cancer is one of the most common forms of cancer in females. There has been an emerging belief that dietary interventions can significantly reduce the risk of development of breast cancer and mortality rate of the disease. Numerous studies have examined the relationship between soy consumption and breast cancer, but not the amount of soy consumption itself. This study is a systematic review of literature in order to determine whether the amount of soy and isoflavones consumed has a positive effect in pre- and postmenopausal women. And the purpose of the study was to answer the following questions. Does soy and isoflavones consumption increase breast cancer risk? Does this effect apply to both pre- and postmenopausal women? The purpose of the study was to carry out a detailed and up-to-date review of literature on soy consumption with emphasis on the amount of soy and isoflavones being consumed on how that affects the breast cancer risk. This meta-analysis study investigates the association between soy isoflavones and breast cancer risk in pre- and postmenopausal women. The key focus was whether soy consumption lowers breast cancer risk based on the amount consumed. And in the inclusion criteria, the studies included were prospective studies, only human population were studied. And the study have sufficient evidence on consumption of isoflavones for an extended period of time compared with the group that lacked consumption of isoflavones. The studies excluded were when the inclusion criteria were not met and the cell culture studies, animal studies, case series, and case reports were excluded. And coming to materials and methods, this is a meta-analysis. The data gathered were performed following PRISMA guidelines. Narrowing down the results set for all relevant data was performed via title, abstract, full text evaluation, and snowball procedure. The selected articles had all relevant data, and the analysis of the data was performed using Cochrane Review Manager statistical analysis tool in order to draw conclusion regarding the positive effect for the amount of soy isoflavones consumed. A total of 441 studies were identified. As this picture shows, the PRISMA guidelines study methods. Initially, records identified were 523, and after all the duplicates records were deleted, 441 tiles were reviewed and the abstract were screened, and full text articles assessed for eligibility were 85, and finally the studies included in quantitative synthesis were 8. And coming to the summary of the total 8 studies, and the studies were divided into pre- and postmenopausal, and the 2 groups were constructed with one group 0 to 15 mg per day of consumption of isoflavones, and one group greater than 15 mg per day of isoflavones. After the evaluation, 8 studies were included. All studies selected has been performed from 2003 until 2021, containing data from patients all around the world. Significant results were found when statistically analyzed data from prospective studies which compared soy isoflavone consumption, breast cancer risk, and occurrence. The data were indicative of a clear inverse correlation between the amount of isoflavones consumed and the breast cancer occurrence in pre- and postmenopausal women. And this forest plot shows the proportion of women diagnosed with breast cancer in the 0 to 15 mg per day group when was significantly higher when compared to the group that consumed more than 15 mg per day of soy isoflavones. From the total number of breast cancer cases, that is 75%, belong to 0 to 15 mg per day of group, while only 25% belong to the group consuming greater than 50 mg per day of soy isoflavones. And this forest plot shows the proportion of women belonging to no to low consumption group and diagnosed with breast cancer was 1.37% of the total population and was almost fourfold the proportion of women belonging to high consumption group. This figure also shows that of the entire population, only a small percentage of participants of both high and low consumption groups were diagnosed with breast cancer, that is 1.73%. This picture demonstrate that amount of soy isoflavones consumption for premenopausal women can indeed significantly influence the risk of breast cancer in population. Out of the total 5,195 premenopausal women with breast cancer, 77.3% consumed 0 to 15 mg per day of soy and isoflavones and were diagnosed with breast cancer, while only 22.7% consumed more than 15 mg per day and were diagnosed with breast cancer. And this forest plot shows the proportion of breast cancer cases for women that had high soy and isoflavone consumption in their postmenopausal stage was less than their counterparts with low consumption. Out of the total 9,305 breast cancer cases diagnosed in the 5 studies, 77.5% diagnosed with breast cancer belonged to 0 to 15 mg per day group, while only 22.5% belonged to greater than 15 mg per day group. And findings from all the 8 prospective studies on soy and breast cancer association that were included in this review were inconsistent, which may be due to different level of soy intake across various studies and may be due to heterogeneity of the data and the different characteristics of the examined population. Cohort studies conducted among women with low, that is 5 mg per day or moderate dietary intake of soy isoflavones did not demonstrate a clear association between breast cancer risk and soy intake. Among the studies reported moderate soy consumption, 3 agree with the conclusion that there is no correlation between daily consumption and the risk of breast cancer. Nishio et al. Found no significant association between consumption of soy products and breast cancer risk. Morimoto et al. Mentioned that in Japanese American and Native Hawaiian or Latina population, subgroups in which the median isoflavone intake was higher than the other ethnic groups, they did not find a statistically significant association between high absolute isoflavone intake or overall breast cancer risk. In a study performed by Wei et al. In over 3 lakh women across China, the dose-response meta-analysis that was performed on the data failed to reject the linearity assumption between breast cancer risk and soy isoflavone intake. 2 of the studies in which the amount of intake was compared between the more than 2 groups, it was found that there was a reduced breast cancer risk for the group with the highest soy consumption when compared to women with the lowest consumption group. Paglia et al. Reported that high soy intake during adolescence and adulthood was associated with reduced premenopausal breast cancer risk. Yamamoto et al. Found statistically insignificant inverse associations between consumption of miso soup and isoflavones in general and breast cancer risk. When comparing with women in the lowest quartiles of the population pool, higher consumption quartiles had adjusted relative risk of breast cancer of 0.76. Accordingly, in statistical analysis of the data compared from these 8 studies, all comparisons were of greater significance and showed a favorable outcome for the group with high soy isoflavone consumption that is greater than 15 mg per day when compared to low consumption group. Initially, out of 9,699 patients that were diagnosed with breast cancer, in 7 of the studies, only a quarter belonged to the high consumption group, with most belonging to the group that consumed none or up to 15 mg per day of the isoflavones. In 4 studies that examined soy consumption in general population, a very low proportion were diagnosed with breast cancer, that is 1.73%, despite the menopausal stage, and again, only a fraction belonged to high consumption group. And coming to conclusion, most of the studies were inconclusive and some of them shows a statistically insignificant result only for postmenopausal women. In the study, they concluded that soy consumption and therefore isoflavone intake is beneficial for breast cancer prognosis and lowers breast cancer manifestation. Women with high soy and isoflavone consumption have a lower risk of being diagnosed with breast cancer when compared to women that do not have a soy in the dietary plan. It also reported that high consumption of soy and therefore isoflavones post-diagnosis of breast cancer is associated with reduced death rate. A variety of new studies were conducted across the globe. Scientists should continue investigating soy and its beneficial properties and hopefully use it appropriately to minimize the risk of breast cancer manifestation. Coming to the strength of the study, it is comprehensive meta-analysis. The study systematically reviews multiple prospective studies across various populations, covering a significant amount of data over a long time frame, ensuring robustness of the finding, and also it includes from different geographical regions, making the conclusion more globally relevant. Focus on the soy dosage. The study specifically investigates the amount of soy and isoflavones consumed, which adds specificity to the analysis and enables a clearer understanding to the relationship between soy intake and breast cancer risk. Pre- and post-menopausal analysis. The study separate analysis for pre- and post-menopausal women, giving insights into how soy affects different physiological states, which is a unique aspect of often covered in area research. And the study uses PRISMA guidelines, ensuring transparency and rigor in the literature search and selection processes. The statistical analysis were performed using Cochrane Review Manager, providing confidence in the robustness of the finding due to systemic use of recognized statistical tool. Coming to the limitations, the study includes study where vary in how they categorize soy consumption levels, making different comparisons challenging and introducing some degree of heterogeneity into the analysis. And the The data used for analysis were largely gathered via food frequency questionnaires, which can be subject to recall bias and inaccuracies in estimating actual soy isoflavone intake. And the exclusion of cell culture and animal studies, although focusing on human data, strengthens the study's relevance. Excluding the animal and cell culture studies may limit insights into the underlying biological mechanisms. And while study includes 8 relevant studies, the total number is still relatively small for drawing indefinite conclusions, particularly when broken down into subgroups like pre- and post-menopausal women. Although the study attempts to control for co-founders such as menopausal status and lifestyle factors, there may be still unmeasured variables that could affect breast cancer risk, like genetic predisposition or other dietary elements. And lack of longitudinal data. While the study looks at breast cancer incidence, it does not deeply explore long-term survival or recurrence rates, especially in relation to soy consumption after diagnosis, which limits the understanding of soy potential long-term benefits. Thank you. I thank Dr. Hepzibah Madam and Oxy for giving me this opportunity.
Thank you, Raghavi. It's a well-organized, very crisp presentations. You thoroughly enjoyed doing the presentations that this journal reviewed. And I will ask Hepzibah Madam.
Yeah, that was a wonderful study, I should say, and she has presented it in detail. But the drawback, though it is a meta-analysis, out of searching so many journals, only 8 studies were included in the final analysis. And as she pointed out the limitation and the strength, the data is very much inconclusive. Though it grossly says there is an inverse relationship between the amount of soya taken with breast cancer, and most of the studies, it is not statistically, it is not comparable with the other studies. So, though it is a meta-analysis, it's a wonderful way to analyze. The study is not, we are not able to come to a proper conclusion because we do not know the dietary pattern, whether it's going to affect the breast cancer in long term and for the recurrence. That is very important. The social impact of this study is not that much valid. That is the drawback in the study.
May I make a comment?
Yes, ma'am.
Yes, madam.
Basically, it's a meta-analysis, and I congratulate Dr. Raghavi for presenting it very well. We think that breast cancer has multifactorial effect. We cannot just say that it's because of the soy intake it has been influenced, because breast cancer has genetic factors, hereditary factors, familial history, then also lifestyle, obesity, diabetes, as well as all these lifestyle factors, alcohol intake, that can also, and lesser number of children, less amount of breastfeeding. All these are compounding factors, risk factors for breast cancer. So we cannot just correlate one factor with the incidence of breast cancer. That is one thing that I wanted to know. And second thing, when you're doing a meta-analysis, maybe the population is heterogeneous. We do not know which age group has been taken, what area has been taken, which global area has been taken. So these are the, I think, the limitation of the study. And they have not addressed these points in the meta-analysis. Of course, you have done a good job because you have presented it very well. But these are the, I think, the limitation of the study itself. But anyway, it was a great presentation.
Thank you,
I must congratulate Dr. Raghavi for doing it well.
Thank you, ma'am.
Yeah, that is the thing she pointed out in
it's
the
an
limitation.
Exercise for all the PG students. So this, her exercise has been great, but the content of the study had some flaws.
Yes, yes, ma'am. She has rightly pointed out about that, the limitation.
Yeah, that is what I'm saying.
They have not taken the confounding factors. They have not eliminated. The only relationship with the amount of soya intake. If it is less, it has got an inverse relationship. So it is, though it is a meta-analysis, And this study is not well appreciated. That's what I think.
Many questions.
FC, it is a good exercise for the meta-analysis for the postgraduates, I think.
Yeah.
No?
Yes, that I agree. That I agree, madam. But that study,
correct.
We know
I also
about
agree
the
with you.
limitations.
Agree with you because the statistical significance is not there, and many limitations she has put there.
Yeah.
Okay.
But yes, Dr. Raghavi has presented it very well.
Thank you.
Thank you for the opportunity for my PhD, madam. Thank you so much. Thank you, Oxy team.
Thank you,
Dr.
FC
Priya
and Dr.
Deepa.
Yeah, I must thank Dr. Priya for making me a part of this illustrious learning during this evening.
It's our pleasure, madam. Thank you, madam.
Thank you, Dr.
Mala. Thank you. You are doing a wonderful job. Good.
Thank you.
Keep up the good job. Thank you.
Thanks, madam. And I think there is no more questions in this journal. Thanks, Dr. Mala, madam, for joining for today's evening. And thank you, Dr. Ajit, presentation. It was also an excellent presentation. And thank you, Anbu. Thank you, Anjalakshmi, madams. And
thank you.
Thank you so much for joining.
Video presentation, I missed.
Thank you, ma'am.
Madam, we will share the YouTube link, madam. It will be shared so that you can meet all the videos. So it was very nice. The Sentinel, we should not miss at all. We hardly get these things to see. It's very nice, madam. We'll share the link, madam. Thank you, ma'am.
Thank you, Priya. Thank you.
So,
thanks, Priya.
Deepa, madam, can we?
Thanks, Priya. Thanks, Deepa.
Thank you, Tepsi, madam. Thank you. So we can end the session, madam. Thank you, Sheel, Pama, and thank you, Sahiti, for being with us. Thank you, Sahiti. Thank you for all the help.
For the behind the screen, the help, she made the flyers and arranged everything. Thank you for the platform. And we'll see you next month, Journal Club, Sagiti.
Yeah.
And please share the YouTube link as soon as you got the link, Sagiti. And there are some more chat box questions. Anything important, Priya?
No, it is only congratulations messages.
Yeah, it's very nice. Now the students are improved in the way they are doing a journal review is great. No.
Yeah.
That's a madam's unit. We don't have to say anything.
True.
Yeah. So we'll close the session, Priya.
Okay, ma'am.